Now remember, this is the tragus, this is where the joint is. A lot of people tend to palpate the joint here or here or here or here, and that's not where the joint is. Alright, if you're unsure of where the joint is, ask the patient to open and close, open and close, open and close, open and close, open and close. And try to keep doing that, open and close. Perfect. I can feel his joint rotate right here. Why now? Because if I ask him to open wide, open, there is an immediate dip. Can you see a dip here? That dip means the condyle has translated away. So when he closes down, the joint will come back to that exact same position. What is that? That is the lateral pole of the condyle. Can we palpate the medial pole of the condyle? No, we can, however, palpate the lateral pole. So if I were to press here, alright, press and hold for a few seconds and ask the patient. And remember, when you're doing that, don't go like this. Stabilize. Alright, it's important that this is stable and then you press here. Alright, ask the patient if there is any frank pain. If there is pain, what is going to be your diagnosis? That's the source. This would be capsulitis, because the only structure that you have on the lateral aspect is the lateral collateral ligament and the capsule. Alright, so we call this capsulitis. How do we check for retrodiscitis? Open wide, open wide. This is where you will put your finger inside the patient's ear. Alright, so it goes in and not like this but forward. Open wide, keep it open. Perfect. Now try to close. Now when you do that yourself, you will be able to feel the condyle come and touch the pulp of your finger. When closing, if the patient says, oh, that hurts, your diagnosis is retrodiscitis. If there is positive palpation from the side and the back, it's capsulitis plus retrodiscitis. Regardless of your diagnosis, if it's an itis, which means it's inflammatory, if it's a TMJD, you are looking at either an anterior repositioning splint or a stabilization splint. This is a classic situation where an anterior stop appliance is contraindicated. Now imagine he's not in frank pain, but he is healing. Alright, so there is a joint pathology and he is healing. Or I have completed splint therapy and I want to check whether pseudodisc formation has been achieved or not. Or I want to differentiate whether the pain is coming from a muscular source or from the joint source. I'm not 100% sure. The most definitive way of differentiating muscular from joint is load the joint and see the response of the patient. So how do you load the joint? You do this with the help of cotton roll. Alright, what will you do? Open your mouth. Place it on the terminal molar, bite down and press. Now remember, the masticatory system is two condyles like this. I have just placed a cotton roll on the terminal molar on the right side. So what have I done in a sense? I have distracted this joint, I have pulled this joint down more than this joint. Now, stabilizing his head with my palm on the other side, I'm going to push this joint upwards. What am I doing? I am loading this joint on the left side. If my patient says, this pain is coming from retrodiscal tissue, it means the disc is not in its correct position. If there is no pain on loading that joint, there is no TMJD or there is pseudodisc formation. Okay? Open. I will now do the exact same thing to the other side and bite down, keep it pressed. So what have I done now? I have distracted this joint. Now I'm going to go ahead and put pressure upwards here. When I put pressure upwards here, what am I doing? I am increasing the load on the right side. And the left is already distracted. So loading the right side, if all the forces are going through the disc, my patient has zero pain. Zero tenderness, zero discomfort. But if there is discomfort, the slightest bit, something in the joint is not in its proper position. Another way of doing this is, open please, bite down with your front teeth, bring your jaw forward and take it back as much as you want. Now when the patient brings the jaw forward and takes it back as much as the patient wants, now what is happening? This is functioning like an anterior stop appliance. With that, I will now hold this, cup this and pull back and up. Try and understand, I'm doing this with my fingers and with my palms I'm doing this. So I'm pushing the condyles at the back upwards and I'm pulling this backwards. So backward and upward. This is your antero-superior direction of force. If the patient says no discomfort, no tenderness, load test is negative, this is not a joint pathology. If the patient has pain, it is not coming from the skeletal framework. It could be muscle, it could be nerve, it could be sinus, it could be vessel, it could be a combination of others, but it is not the TM joint. Are we clear with this understanding? Yes.